So at this time, I would like to introduce our keynote speaker, who is actually intimately aware of the work that we've done in South Central Pennsylvania. Because he currently serves as the principal investigator for evaluation for Robert Wood Johnson's Aligning Forces for Quality program. Dennis is a professor of health policy and administration in the College of Health and Human Development and director of the Center of Healthcare and Policy Research at Penn State University. His research focuses on the understanding of the role of measurement, incentives, quality improvement, and individual and organizational behavior change for improving important healthcare outcomes, breathe, including clinical quality, patient experience, and economic efficiency. All the stuff that we've been doing in Aligning Forces Quality. He serves on the editorial board of several journals, including Health Services Research, Medical Care Research and Review, and recently appointed Associate Director of American Journal of Managed Care. He is the 2014 recipient of the Evan G. and Helen G. Patashal Outstanding Research Achievement Award given by the College of Health and Human Development at Penn State. The honor awards faculty members outstanding research contributions occurring or culminating within the last several years. In 2005, he was the recipient of the Fran and Holly Soestman Faculty Development Award, which honors a faculty member's engagement in significant innovative research related to the design, development, delivery, administration, or evaluation of healthcare services. He received the John D. Thompson Prize for Young Investigators in 2002, given annually by the Association of University Programs in Health Administration to an outstanding young investigator in the field of health service research. He was also awarded the Robert Wood Johnson Foundation Investigator in Health Policy Research Award in 2002. Dr. Scanlon has served on several national, local, and international advisory panels for organizations such as AHRQ, NQF, the Commonwealth of Pennsylvania, and the European Commission. He has published more than 100 articles, book chapters, and reports. He completed his bachelor's degree at Villanova University, earned a master's degree in economics at the University of Pittsburgh, and completed a doctorate in health services organization and policy at the University of Michigan. You were a child prodigy, right? This was all, right? So please give him a warm welcome.
Thanks, Chris. I hate listening to people read that. You know, at the university we get paid for how long our bios are, so that's the only reason it's that long. But it's wonderful to be here. And as Chris mentioned, I've had the distinct pleasure for the past 10 years of studying 16 places across the country that have done work like you all have done here in South Central PA. And as that video illustrated, you all have done the hard work, you know, sort of engaging in these difficult conversations at times, thinking about process improvement, working with patients. My job has been kind of fun. We've been able to sort of try to look at 16 places across the country and understand how every place does it a little bit differently, though still trying to reach the same goal. And I would say, and as I'm going to try to share with you tonight, it doesn't always work out perfectly. And I think the challenge and the reason why the Robert Wood Johnson Foundation and others, when they do programs like this, want to study it is to try to harvest the lessons for how we can scale this work up in other communities. You know, you've done this here in South Central PA, but we have many communities across the Commonwealth, other different states and places across the country. And the idea is how can we sort of scale this through policy, through payment, through the will of patients and providers to get to the point where we want in our healthcare system. So I'm going to talk tonight, I've titled this The Missing Chapter, the health reform story at the local level. And the theme here is really a story because I think that much of, as I'll describe, much of what we hear on a day-to-day basis, if you listen to the news, if you turn on the radio, is the political rhetoric at the federal level about how healthcare is so broken and nobody gets along. And I think that when you see videos like you just saw and when you hear stories about the work that's being done on the ground, you realize that there really is hope for our system if we can get folks like you who are at the front lines working together and, again, think about how to scale that up. So I am going to start with a little bit of what's missing, and that is the story is most commonly told at the federal level or from the perspective of the red states or the blue states. We want to politicize a lot of this in healthcare, and the common chapters in this national story is a lot of rhetoric, public perception, discussions about an evidence base that may be lacking, politics and legal challenges. And these are the things that we often hear, if we listen to the news and we do that. And so I think the easiest way to kind of illustrate what many Americans think about our healthcare system and the politics of it is through a series of cartoons. If I can, skipped one. March 23rd, 2010, when President Obama signed the ACA, that sort of set off a big political firestorm that has continued until today. Obviously, you can see the thumbs up with several of the pictures in the background, but this has become a very polarized topic. You may remember this. Vice President Biden, this is a big bleep deal, and of course the microphone was on, and the other side saying, "Sure, at least we agree on something." Wondering if it covers antidepressants, as though the sky was falling as a result of our healthcare reform. And accusations that healthcare reform at the federal level includes side effects such as socialism, high deficits, denied coverage, abortions, fewer doctors, death panels, and I'm sure a variety of other things too that are in small print below the label. And so there's a tendency, I think, in what's covered to believe that this is really where we are in healthcare. But if we think about the local story, in other words, the missing chapters, it paints a very different picture. I would argue, having studied a lot of different places across the country, that the problems are reasonably well defined and accepted. We have agreement on sort of what is broken and what needs fixed. We don't always agree on how to get there. And local context is of critical importance. We need to consider the local economy, of which the largest employers in many communities across the country are healthcare providers and healthcare systems. We need to think about provider insurance competition in the culture of working together in collaboration, which exists in some places but certainly doesn't exist in others. So the debate is generally focused on the degree to which we want the government to be involved in the solution, even though I think there's common acceptance that of some of the problems. We'll talk about those in a moment. The challenge here is the evidence base for proposed solutions is lacking, and I think those of you in the community who did the work in the video of empowering patients, of thinking about quality improvement, there is some evidence that one can fall back on, but a lot of the work that you and others across the AF4Q communities have done really had generated through experimenting and piloting your own kind of unique solutions. And I think there aren't as many turnkey solutions. And so we have to realize that a lot of what's needed is there's not a manual, there's not a handbook necessarily, even though there's some guidance certainly. And as a result, we have many demonstrations going on around us. The good thing is we have many demonstrations and a lot of will. The challenge in terms of scaling, again, in payment and policy is to think about, sort of the chaff from the wheat. What works and what is worth investing in versus, what feels good and may be more based on anecdotal evidence. The time horizon for health reform is certainly very ambitious, but fundamental change takes time and doesn't follow political calendars, and we all know there will be winners and losers, and that creates difficulties from a timing perspective as well. Innovation needs to be rewarded, but it's needed, but it needs to be rewarded. And in some sense, maintaining the status quo is the same thing to do for many providers until kind of everyone figures out what the new roles of engagement are going to be. And when we tie things like payment to incentives to desired outcomes, it makes sense conceptually, but it's difficult practically. And we've seen that recently in the Medicare ACO space, where both in the Pioneer ACOs and some of the shared savings programs, we've had a lot of participants decide that it just wasn't worth continuing to participate. So what are those problems that we're trying to address in healthcare? Just a quick review. High cost, and I like to think of this from an employer perspective, offering health benefits. Over $8,000 annually per capita, and probably closer to about $18,000 for a reasonable policy for an employer like mine for family coverage, or maybe about $6,000 for individual coverage. We have unequal access, uninsured and underinsured, and even with the ACA, with high deductible plans and and some of the cost sharing that consumers face, I think this issue of underinsured really comes into play quite significantly in this country. Asymmetric information. So we don't have the information that other markets have on price, cost, quality, safety. And health has really been slow to incorporate the advantages of HIT. Even after pumping billions of dollars into HIT from the federal government's perspective, we find that it's not used in clinical care always to its to a great degree of effectiveness. That varies, of course, by providers. And there's certainly distorted incentives. Fee-based reimbursement, third-party insurance, all of that serves to complicate things. We have a system that's built on short-term acute care focus, heavily compensating specialty care versus primary or preventive care. We have fragmented delivery systems, special interest. This is 17% of the U.S. economy, and as such, there's a lot of dollars and a lot of people who stand to win or lose based on those dollars. And it's heavily regulated while unabashedly capitalistic. And I don't care what side of the aisle you're on. I mean, this is sort of an anomaly of the U.S. healthcare system relative to other places around the world, is that we do have, given our culture, kind of a high reliance on the market, but yet very much a socially built system in the U.S., given our social insurance programs. A way to sort of illustrate some of these, and I'll go through these quickly. If you look at this trend between the cost of employer-sponsored insurance, the dark blue is what employers have paid, and the light blue is what employees have paid. Look at those trends in just 10 years, 2003 to 2013, and you can see quite significant growth, and significant growth in out-of-pocket cost on the part of families. And this is where wages have not increased to keep up with this expenditure. So real dollars here at play, both for employers who are trying to compete in an ever globalized market, but also families who are trying to survive. Probably hard to see some of the details here. This is from an organization called Catalyst for Payment Reform. But if we look at price variation for healthcare services, and this is for maternity care, broken down by both C-section as well as normal vaginal delivery for various risk severity categories, you see multiple fold differences, as much as 700% in terms of the prices that are paid for seemingly a similar set of care that's delivered. And so the question, it's sort of like going to Giant versus Weiss Markets versus whatever other grocery store is, and paying 700% more for a box of Cheerios in one place versus the other. It doesn't make sense to those who are paying the bill in many respects. The bottom line here, I think, is the one down at the bottom. This is an estimate from some work that was done on the percentage of the healthcare dollar that can be attributed to costly waste or inefficiency. And sort of the lowball estimate is 21%, 20 cents out of every buck. The high ball is 47%, almost half. So pick your favorite number, but the question is, why are we paying for care that is costly in terms of waste and inefficiency? And couldn't we be doing more with those dollars? So we talked about, sort of the capitalism part. I mean, and this is sort of meant to get at that. We're bombarded with this, right? Sort of pills, brought to you by red pills, blue pills, purple pills. Ask your doctor if pills are correct for you. So make sure you do that tomorrow. Maybe email your doctor tonight, although they may not respond because they don't get reimbursed for that. When we think about all this, and this was from Elliot Fisher at Dartmouth, who put this slide together and sort of has allowed me to use this, we think about opportunity cost. So in the Medicare population, this is sort of per capita spending rates for different cities in the United States. You can see that Miami, at this point in time, was the most expensive at about $16,351 per Medicare beneficiary, whereas the U.S. average was $8,300. So quite significant variation for the same risk-adjusted general aging population covered by the Medicare program. And so if you do the thought experiment of what if East Long Island had grown at the San Francisco rate, which was less, that would save the federal government about $1.4 billion. And, if the U.S. grew at the San Francisco rate, that figure goes up to $1.4 trillion. So if we think of this in the context of opportunity cost, roads, bridges, economic development, school, education, military, a lot that we could potentially do if we could capture some of the savings. And if we think about that at the state level as well, in state expenditures, where Medicaid and health expenditures at the state is consuming 40% or more of state budgets, lots of opportunity if we can kind of get a handle on this. Just as one might do in a family budget if you think about reducing your spending while still keeping your consumption fairly similar. So, what are the solutions? Well, I think that it's a mix of federal, state policy, and local implementation. And tonight we're here to celebrate and talk about the local implementation. It's important to recognize that the federal ACA and legislation has done some important things. And I won't talk in detail about these, but, insurance reform, certainly that was a cornerstone of the Affordable Care Act. We know that more Americans have insurance as a result of the ACA. There are some hiccups, certainly. And if we, and I won't go into the details, but that was really a big cornerstone of the Affordable Care Act. The Affordable Care Act is also focused on delivery system redesign and payment reform, a lot of work by CMS through the Centers for Medicare, Medicaid Innovation. There's been some focus on workforce composition, the use of health information technology, which actually preceded the ACA with the HITECH Act, but has continued to be supported, and then others as well. If we think about the state and the state's role, we can focus on Medicaid expansion, which, of course, based on the Supreme Court ruling, was a state-level decision. The state innovation modeling plans that CMMI made available to many states, and Pennsylvania now is going through its second version of that planning grant. Many states, I think Washington State recently received something on the order of $60-70 million to implement their plan, largely focused on these issues. There have been investments in transparency through the CMS work that they've done, as well as some things on regulation of insurance and provider markets. So, for example, pre-existing conditions or children up to a certain age being allowed to be covered on parents' policies. So all that's sort of what's been done at the federal and the state level, and that's kind of a crash course. But then we get to this local level, where I think the story has been missing. And it's an important story. So I'm glad to see the videos like were created here. And I think we need collectively to talk about the local work that's done, because that has to bubble up to policy and that has to bubble up to payment. And the problems as well need to be communicated. And I think it's not always what reporters cover. Sometimes we don't have local reporters anymore in many towns that are even covering these stories. So it's really critical to share the story. And I hope that you'll sort of circulate that video, because I think others need to see it. So the video talked about aligning forces for quality. This is kind of the RWJ tagline, 16 communities, 37 million people, one goal. As RWJ said back at the beginning of this, AF4Q asked the people who get care, give care, and pay for care to work together towards common fundamental objectives to lead to better care. And the question is, how did that play out? And so one of the things that we were charged with is to really sort of study that somewhat systematically. The foundation really says that they value the notion of sharing lessons learned. And that doesn't mean that everything should be sugar-coated. That doesn't mean, certainly when I take jobs like this as a researcher, it's to sort of tell it like it is and to try to tell it like it is. It's incredibly difficult, by the way, to do when you've got so much in flux and so much happening. But that's what we've set out to do, and I want to tell you a little bit about how we've done that and what we found. This comes from a member of the AF4Q National Advisory Committee, and I think it's somewhat apropos. This was in an interview that we did, and this individual said, I think the thing that's happened is that aligning forces has contributed to the idea that if you want to change healthcare culture, the way healthcare is being delivered in a community, you really can't do it just top down by enacting federal policies. And I don't think that surprises any of us. But the idea that innovation and change have to happen locally is more credible now, and I think we're seeing more collaboratives, some funded by other sources or some coming together more naturally, because people are realizing that you need multi-stakeholder commitment. You need to work across providers and settings of care if you're really going to start to make change and improve quality and lower cost. And that really is sort of the theory behind the Aligning Forces for Quality program. But I mentioned this earlier, evidence is key. We'd all like evidence to implement. If I want to be a better teacher, I'd like to sort of learn what's been studied and what someone else has done so that I can take that into my classroom and not necessarily have to invent this myself or experiment or try multiple things, although sometimes experimentation is certainly good. I tell kind of people, relatives, others at, holiday parties, when they ask about health reform, I try to explain if we really knew what worked, presumably we would just do it. It's not that simple. So a lot of what AF4Q did was tried to kind of create those solutions. And of course, it's kind of like pharmaceutical development. For every 100 things you try, some are going to work and some aren't. And you hope that you learn which ones do and which ones don't and what to continue to invest in. So there's a lot of anecdotes and sound bites out there in terms of what the right solutions are. But the evidence base is sorely needed. And it's very difficult to kind of develop that evidence base when people are on the ground kind of trying these things. We don't want to reinvent the wheel, but we have to make sure that the local context is considered and appreciated. If you're in a market with very consolidated delivery systems and heavy, not so much competition on the payer side, what you can accomplish or do is much different than if you're in a market with a tightly integrated delivery system that may be nonprofit and have a history of being civic-minded within the community. And so that's part of what we look out for as we study AF4Q. This notion that there will be winners and losers, and the losers don't go away lightly, is probably not surprising, but it's critically important. It's how to take the losers, and by losers I mean those who stand to the way they operated historically doesn't really fit where we're going in healthcare. They don't want to give up that revenue stream, and so you have to think politically and socially how it is that we acculturate them to the fact that the world is changing, and they either need to change or they need to disappear. And how those are brokered is very skillful. So lots can be learned about how this is played out across multiple communities. This is an article by Don Berwick. Many of you quality improvement folks sort of know who Berwick is, the head of IHI. This received a lot of attention because it really sort of illustrates the debate of developing science in these areas of rapid cycle improvement change. And I won't get into the details, but suffice it to say that around rapid response teams in hospitals responding to patients that crashed, IHI took this on and through partnerships with a lot of folks found that they believed that it was beneficial to sort of educate and train hospitals on these rapid response teams. And, they did this more in a qualitative sense. So then there were some researchers from another country that came and tried to do this in a randomized controlled trial sense. And everybody thinks the RCT is the gold standard. Well, lo and behold, what they found is that rapid response teams supposedly didn't work. And this sort of set off this firestorm of what does it mean to develop scientific evidence around what works or doesn't work when we're doing improvement. And it's very interesting because as Berwick kind of picked apart this so-called RCT study and the quantitative evidence, what he found is that there was spillover between the concept of the control group not having rapid response teams, but lo and behold, they did. Why? Because they thought it was valuable, and they didn't want to sort of withhold that even though they were in the so-called control group. There were also power issues and things of that nature, and so it just really underscores the challenge and our challenge in studying this of sort of identifying when evidence sort of is solid, when evidence is not solid, or quite frankly, when we're not quite sure. So our goals in the AF4Q evaluation, which Chris asked me to talk about, was to try to provide inferences about the effect of this program as a whole and the specific cases in communities like this and others. And we do that by looking at descriptive data, by looking at trends, by looking where possible at causal estimates, to try to identify key lessons about the program design, implementation, and effectiveness, and then to expand the knowledge base around community-level health improvement strategies and this collaborative multi-stakeholder approach. So this was our logic model, and this is kind of a research tool. And I present it here because I think for those of you that aren't as intimately familiar with the components of the AF4Q program, this will give you a sense of the Robert Wood Johnson Foundation's theory of change. If we sort of start with the right-hand side here, these so-called longer-term outcomes, these are really changes in population health outcomes. We want healthcare to be more affordable. We want patients to be healthier. That is really hard work, right? And that's going to take some time to accomplish. But if you start to go to the left, you might observe some intermediate outcomes along the way. If we put together price transparency or quality transparency, maybe we have more transparency in the healthcare market in the community. If we start to engage our patients, maybe the conversations change. And as you go further left, these interventions, which might be a little bit difficult to read, are all the ones that were highlighted in that video. Quality improvement, consumer engagement, transparency in public reporting, focus on payment reform, and equity. And that really was the theory of aligning forces. And so all those different segments that you saw in the video was really set forth by the Johnson Foundation and its program, the belief that if communities would take these various components on and do it in their own way, it would bubble up eventually over time to improvements in these longer-term outcomes. And oh, by the way, how do communities accomplish that? Well, they accomplish that through this green box, which is getting multiple stakeholders to work together. Stakeholders who sometimes are at odds with each other. Payers who are contracting with providers, providers who are competing with other providers, consumer agencies or advocates who feel that they're marginalized or disenfranchised and the system wasn't created or doesn't evolve from them. So the idea in this grand thought experiment is if we can get people to work together collaboratively and put these interventions into place, we will achieve better outcomes. And so this really has guided our evaluation. We've tried to collect data in all 16 places as well as other places across the country that did not have the AF4Q experiment and really sort of understand what's happened. And so I'll just share a few examples of sort of some of the things that we found. And I'll reference a couple different papers that we've wrote. And if anyone's interested, we have all of this detail on our website. But the first thing is this assumption that people will work together. And it is a strong assumption for any program. We at the very beginning said to the Robert Wood Johnson Foundation, don't assume that will happen or that will happen equally. And as it's played out, it doesn't happen equally. There are places that are now closed down. Their AF4Q program no longer exists, largely because they could not broker those community-level collaborations. And so we tried to study that, and we tried to study sort of how that happens or doesn't happen. And for those of you that are interested in organizational life cycles or organizational culture, a lot of what you see is kind of this cycle where there's the emergence of these multi-stakeholder partnerships, and some places started with that in-house more than others. Some places develop that de novo. They start with sort of the broad goal, sort of who needs to be involved, what's our mission. They sharpen that in a transition phase, review not only their organizational structure, but what their mission and goals are, move to kind of organizational level maturity, and then ultimately where many places are now, which is this critical crossroads in deciding, based on what we've done, is this worth sustaining? And what is worth sustaining? Is it everything that we've done? Is it part of what we've done? And how do we actually sustain that? Who's going to pay for it? Because part of the Robert Wood Johnson Foundation's experiment was to pull the plug on funding after 8 years or 10 years. Specifically, they wanted to create a situation to see if what was created in the community had enough legs or had enough value so the community would take this on and figure out how to fund it. So, the question is, what should be sustained? Is it the interventional work, the patient partners program, the pharmacy bags, or anything else that you've done here in South Central PA? Is it all of the above? Or should some components perhaps be given more priority than others? What about the infrastructure, the staffing, the buildings, the lights, the office space? Or should some of this be moved into the community? So it's been developed and seeded, but it really needs to be owned within existing organizations, health systems, payers, provider groups, and bricks and mortar organization isn't necessary anymore. These are all questions that many of these communities have been asking. And really the foundations of sustainability is this notion of creation of value. But there's a public good problem here. These community initiatives create something like the park that everybody likes to use, but maybe nobody wants to pay for, nobody wants to clean up. And so that really is the challenge of sustainability, is if we think we've created value, who pays for it? And that really is the difficult conversation, and hopefully one we'll get into on the panel in just a little bit. So, there's accountability and governance, and all this really matters for these organizations. And we've observed lots of variation nationally. So really there are 4 possibilities, and we see across the 16 communities now that this funding has ended, really some in each of these buckets. There's the alliance surviving in its current form. There are alliances reorganizing into a new entity with a new mission. In many cases, because of the funding problems, there are some of these alliances that have had to take on sort of for-sale work. So for-sale quality improvement work or for-sale public reporting work, because that's what's going to pay the doors to keep the work going. In other places, there have been funding streams coming from state government or coming from, in essence, a portion of the premium to really fund within the community to fund the efforts. But the conversation is, how do you sort of foot the bill to do this work? Some alliances have passed on some or all of its responsibilities to another entity or entities within the community. So they've sort of developed the intellectual property, but then released it to those who are more capable and have budgets to be able to sort of put this forth. And then there have been a few cases, one in particular, and possibly a couple others coming down the pike, where these alliances simply disband, either because its goals have been accomplished or frankly because there really was no support for the work that it was doing. And that was part of the grand experiment. The second area of intervention, consumer and patient engagement, I think this is one where South Central PA, certainly in the A4Q club, has been known for its work quite significantly, among other areas. But there were lots of places that struggled with this. And I find it interesting. We did a very early paper just by going on the ground and talking to folks about what does consumer engagement mean. So it's published in Health Affairs, and you can see the subtitle here. The yield from these initiatives will be determined by promoters' ability to translate rhetoric into real strategies. And I bet if I asked Chris when she took the job 8 years ago, consumer engagement, patient engagement may have seemed a little bit more like rhetoric. But, obviously based on the video, you guys were able to turn that into reality and I think make a real difference in the lives of patients. But that was not able to happen in all places. And these are three quotes that came from three different physicians early on in one community, one AF4Q community. And I think this illustrates how some of these conversations really start at the basic level. So the first one, consumer engagement is the area that most closely aligns with pushing smoke around a room. It's hard to get your hands around it and define it. It's sort of, well, it sounds good, but we don't know what to do. The second one, at least in the short run, 5 to 10 years, I don't have a lot of confidence in consumer engagement as the way to go. Sounds a little like an excuse to me. The question is that confidence really, I don't want to go there because it's uncomfortable for me. And the third one, we want to choose better quality. We want them to better self-manage, but we also want them to change us to help us, providers, see care delivery through their eyes. And so three physicians, same community at the early stages 8 years ago. This illustrates sort of the uphill battle in trying to do any of this interventional work and why it does move slowly. And if those quotes don't sort of do it for you, then in terms of sort of understanding the differences, I sort of illustrate the same point with cartoons. This says, it's okay if you disagree with my diagnosis. I can prescribe something to make you less disagreeable. This is, again, the white coat is the authority. You will listen to me. We know best. And, sit there on the exam table. Don't ask any questions. Here's a little bit of movement. What fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So maybe a little shared decision-making here, starting to engage the patient in conversation. And then my favorite, this is sort of moving along the continuum to full-blown engagement of the patient. Doctor, I have a question about my medication. Why is the couple in the commercial sitting outdoors in separate bathtubs? So this is inviting the patient to participate in the conversation, and regardless of perhaps how silly the question may be, and meeting the patient where the patient's at. By the way, if you've seen the commercial for this product, they've changed it. I don't think they have the couple, sort of as prominently in the bathtub anymore, but up in the corner where they have the drug name, they use the bathtub as a symbol. So the power of marketing and such. So. This really has been new for healthcare, and I think as the video illustrated, you guys have done a lot. But we've focused on issues of care coordination from the perspective of the patient. What do they think? What constitutes good care coordination? We've written some things on that. We've, I was on a flight recently, and I sort of said, I got to put this into slides. Okay, so this is Delta Airlines, and I'm not sure that many people think of the airlines as the best example for customer service or customer centeredness, but I have to admit, I think Delta has really done a nice job with this. So we land, I turn on my mobile device, and instantly there's a text message or an email that basically, this is my wife, we were traveling together, but it says, we're contacting you because your bag did not travel as intended to your final destination. Isn't that really eloquently stated? It's not we lost your bag, it did not travel as intended. But, literally, as soon as we landed, turn on the device, this message is there. They knew, and they sent this to me, which I appreciated. But it goes beyond that. So, please proceed to the nearest Delta baggage service, blah, 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 blah. We apologize for the inconvenience. So then I get a message that says, dear, they ignored my first name, but dear Scanlon, your baggage is now out for delivery. Your driver's name is Terry. You can see a photo of your driver and follow the delivery by clicking on the link below. And so if you click on the link below, there's Terry down in the left-hand corner. He looks a little burly to me, but it's got all the, delivery. In fact, I can hold my delivery. I can wave the signature. This is really customer service. And so the question is sort of why in healthcare aren't we there, and what can we do to get there? And I think many of these projects have really focused on trying to make things, believe it or not, perhaps more like the airlines. But as we went out and observed all the interventional work that was done in the name of consumer patient engagement, there was wide variation. The things that you all do that we heard in the video, there were some places that felt that it was going to make a difference if they partnered with restaurants and put placemats on tables that basically talked about eating fruits and vegetables. Now, you still have to question how powerful was that intervention. Lots of things that one can do in the name of engaging patients and consumers, and the question is, do they work or don't they work? And we felt that we needed a framework for making sense of these various things to understand them a little bit better. And so we wrote something on this, and the first thing I think that I want to illustrate, and I won't go through the details, this is a model that we developed and it's in the paper. But at the end of the day, as we looked at the literature, we first believed that consumer engagement is something that's easy to say, but really it probably involves about 4 different behaviors. We call them healthy behaviors, getting people to sort of act healthily, eat good food, exercise, that sort of thing. Self-management behaviors for a chronic illness or for prevention, sort of knowing what to do given your disease or given your condition, and taking care of yourself from a medical perspective. Health encounter behaviors, being able to ask your doctor, your nurse a question, even as silly as it may be, like, why is the couple sitting in the bathtub? And then consumeristic behaviors, looking at comparative information, thinking about healthcare shopping. And so a lot of what is done, and I think is sort of thinking about proposing interventions on the part of patient or consumer engagement, would probably be well served to think about sort of what bucket is this meant to focus on. And then ultimately, how is that meant to change patient activities, and how does the intervention do that? So, these arrows that are going to pop up here simply means that we use this framework to take all the different things that were being done in the name of consumer engagement across the country and to kind of map them in this model as a way of systematically understanding what was going on. Community-based quality improvement. We wrote this article, which was a case study. Oftentimes we started our work with single case studies to understand conceptually how places were tackling things. This was in Western New York, the Buffalo and surrounding Niagara counties in New York, building the scaffold to improve healthcare quality in Western New York. And what's interesting about healthcare quality is it again is not typically a community-based initiative. Yes, you have some collaboratives, and IHI has been good to sort of focus different hospitals and providers around certain collaboratives. But oftentimes, QI is what's done within the walls of organizations by themselves, not always with sort of partnership with folks in the community, with some exceptions. Quality is something that organizations sometimes compete on. And so the notion for the Robert Wood Johnson Foundation here was, can we get sort of more a broad-based community quality improvement program? Can we think about quality improvement for South Central PA, quality improvement for the state of Maine? And that really was the goal and focus. So we wanted to see how this was playing out. And as we've done our work, we've sort of have settled on, there really are about 8 different functions that a community might focus on if they were to start. So lessons for other places across the country if you wanted to think about quality from a community-wide perspective. First of all, what is that community-wide vision and strategy? What are the needs and resources within your community? Where are there sort of people who understand this and excel, and where are there people who have a deficit? Raise the awareness of the need for QI, because it often, in building projects and investments and the new cath lab, lots of things often get priority more than quality improvement. Procure and distribute QI resources, and there are resources for QI out there through grant funding, through state and federal programs, through foundations, and if one approaches this systematically, you can bring resources to a community to help address this. Facilitate programs and interventions, bring players together, establish a monitoring system to understand whether this is working, provide a neutral forum for learning and collaboration, and I think that's some of the work that you've done here in South Central PA, and facilitate cross-provider QI, really across the continuum and across the collaboration. It's amazing to me in another project that I did where the nursing home that a hospital discharged the majority of its patients to, really, the administrators of the nursing home and the administrators of the hospital really never met each other until this separate project that we did. And, scratch your head and say, how are we supposed to work together when we don't even know each other? We've also looked at, from thinking about, does this work, how you actually measure and capture the dose of quality improvement in a community. And I won't bore you with kind of the details, but it's a very difficult question. And so as we look across the 16 places and we try to think about how much new quality improvement happened as a result of AF4Q, it's really difficult to answer. And so if you want to monitor and track what's making a difference, you really need to be able to measure it. And so we've tried to do some work in that area as well. Price, clinical quality, and patient experience transparency. I'm an economist by training, a health economist, and economists believe in transparency. It makes markets better. But in healthcare, we've had asymmetric information. And so probably the single most biggest intervention in terms of the volume of work that's been done across the 16 AF4Q communities has been in this area. And so this is from Washington State, also a report called the Community Checkup. You can see it might be a little bit difficult to see, but basically this is a consumer reports type measurement system for chronic illness care, for preventive care, for different providers, and how they did relative to the average on these various measures. Lots of this was developed at the ambulatory practice or group practice level in these 16 Aligning Forces communities. In Massachusetts, they focused on patient experience as well, in addition to the clinical indicators. And there's also been some work focusing on what is become named efficiency or price measurement. We did some work, and this was a paper in the Journal of General Internal Medicine early on called A Report Card on Provider Report Cards, Current Status of the Healthcare Transparency Movement. And despite the federal government's effort and the early AF4Q effort, we sort of rated this about a C-, because at the end of the day, when you look at the number of conditions, when you look at, and this was probably 6 or 7 years or so ago, when you look at the availability of that information, it was still quite limited despite quite a bit of progress. That certainly has improved both in AF4Q and elsewhere since then. So we also tried to track the availability of these reports over time and by region, both on physician quality and hospital quality. And these trend lines basically sort of illustrate that the lighter blue is the baseline period. The darker blue is sort of what happened about 4 years later. And you can see, lo and behold, there's a significant increase in the availability of these reports in many communities. So if we look at South Central PA, certainly more of this information was available over time, both in terms of physician quality and hospital quality. A little bit of a detail here, we include repackaged reports, so there might be a single source, but they might be repackaged by insurers, by community organizations, by others, and we counted those separately. But the point is, we did this because we wanted to answer the question. We also looked at the types of measures, by the way, that were reported. And what you see is conditions, not surprisingly, like diabetes are fairly well covered. But if you go into other conditions like depression, sort of a lot less information for a whole variety of reasons. So this is the gaps in our public reporting in terms of what's available. But what we really wanted to answer is this question: are healthcare quality report cards reaching consumers? And what's the awareness in the population of this information? Because one assumption is that if we put this out there, people will use it in that sort of shopping type consumeristic behavior that I mentioned a moment ago. And so through survey methodology and longitudinal survey methodology, we estimated sort of a population prevalence of awareness of these quality reports in communities over time. And what we see kind of on average is for hospital reports, things stayed pretty consistent. About a quarter of the population reported that they had seen and been aware of a comparative quality hospital-based report, which really didn't change much since 2008. And of course, CMS has been producing this information for a long period of time. We did see some increase in awareness of physician quality reports, going from about 13% to 16%, 16.5% of the population. And so that's an upward tick, and there's variation across individual places. But the question is, why is it so low? Why isn't it as high as hospital quality reports? And is it something about the information? Is it something about the marketing? Is it something about the expectation that consumers are actually going to use this relative to providers using it for improvement and everything else? And consumer awareness is just one of many different ways in which this type of information can be used. So those are some examples. Actually, let me go to this, and I'll come back to the state story here in a moment. Let me go to the next slide if I can get this to click. And I'm going to go a little bit off script here. First of all, controversial national policy has provided a treasure trove of opportunities to study and learn from, but these are done in a non-experimental manner, and it requires sort of a certain type of research to do this. What I would say, and I had a list, some of the key things we're learning as we're wrapping up this AF4Q evaluation is, not surprisingly, leadership in the context of that multi-stakeholder collaboration matter. When you look at the places that succeed and are likely to sustain, oftentimes it's a clinical champion, it's a civic leader, it's a number of influential officials in the community who basically have rallied the troops to say, you know what, enough is enough. This is important for us. And the places who, we predict, and of course we'll see in a couple years, may have less success, are the places who don't have that civic engagement and civic leadership. So that seems likely to be a key ingredient. And it seems obvious, but figuring out exactly who that is and who can champion the cause is critically important. The other thing that sort of plays up is how do you scale these programs? And so, I imagine this is an issue in South Central PA as well, and I think it'd be something hopefully the panel can talk about. As you get into a program like Patient Partners, as you get into any other program, how do you take this out to the masses and reach more than just a small percentage of your patients, either within certain clinical offices or delivery systems? How do you scale it up to population level? And that is probably the single biggest challenge that many places face. There's also a myriad of other policy levers happening at the federal level, at the state level. So how does all this work sort of interface with that when clinicians, when patients, frankly, high deductible plans are being faced with more cost sharing? So all this change is happening in the context of broader change. And at some level, the question is, are we changing too much? Are we doing too much? Is CMS on a course that's moving too quickly given the evidence base? Should we slow it down a little bit? And there are some who believe that maybe we do need to slow certain things down and pick other things up. So, there are more lessons we've learned. We're trying to put together kind of our final analysis officially, and that'll be made available on our website, hopefully by June is sort of our target date. But I want to go back. That's sort of the national story. That's 16 stories kind of locally in AF4Q. I think what's interesting here in Pennsylvania, and actually this relates to one other story I wanted to mention, as we look across these other 16 places as well, many of the places that have been and are more likely to be successful have the benefit of a very proactive state government. They've done Medicaid expansion. They've done the SIM planning grants. They're in the SIM implementation phase. The state has sponsored healthcare transparency. And that's a common ingredient, not in every place, but in many places. There's this local collaborative, like your collaborative here, has been able to work together in partnership with state government and often receive resources from state government. Pennsylvania has been a little bit different, as you know. We've sort of have gone through different gubernatorial changes. We have a new administration now. But I think with this new administration, and it remains to be seen sort of exactly how this plays out, I think there is going to be more of a focus on healthcare. At least that's what they're signaling. We know that we have Medicaid expansion, and that's something that's relatively new, started, of course, by the previous administration, as I understand it. There's a new round of the state innovation modeling planning going on, and that's really focused around these topic areas, which make logical sense: payment, population health management, transparency, rural health, and delivery system redesign. And then also a focus on regulatory approaches. And we'll see how this plays out, because in Pennsylvania, we have some regulatory challenges. In the west part of the state, UPMC and Highmark and the consent decree, which patients don't really, what is a consent decree to a patient? It's very confusing. In this capital area, we have the proposed merger between Hershey and Pinnacle, which is still sort of being subject to review. And with the ACO model and new kind of models, there's a whole question about how do we regulate, or should we regulate those types of arrangements as well. But we have a new insurance commissioner. Attorney General's office has some problems to sort out, obviously, but we'll see what happens kind of coming down the pike there. And there's a variety of other community-based partnerships as well. So, embedded in this national story is also the importance of this state-level story, which can really influence how things play out locally. And so what I think that what I wanted to do before we sort of get engaged in the panel here is also let you know that any of the publications that I referenced or any of the other things that we wrote, we also try to write things for real people, not just academics. So we try to shorten things for folks on some of our work. That's all available on our website at the Center for Healthcare Policy Research if you'd like to read any of that or join our mailing list. We also have some multimedia. This is an interview I did recently on transparency with folks at the Network for Regional Healthcare Improvement. But What I thought we'd do, or what Chris basically designed that we'd do, is ask me to kind of moderate a discussion with that backdrop and really get back to this local story. You saw the video. You heard a little bit of a high-level 30,000-foot summary from me on how this is kind of played out across a couple different places. But I think the panel is really meant to be an opportunity for questions among each other and for you as audience members to ask the panel questions, get into a little bit more detail about how these things have played out. So, Chris, should we start that?